Thank you,
Okay.
sir.
I thank the organizers for inviting me once again to talk on this annual fiesta. I can see a lot of old colleagues and friends of Dhaka, but what I really missed this time is the hospitality of the organizers and the wonderful Bangladeshi cuisine. Incidentally, I am working in Chittagong as a senior consultant in the Department of Cardiology. So the topic here is echocardiographic evaluation of dilated cardiomyopathy and ischemic cardiomyopathy. The terminology has changed to some extent. Really, there is a lot of pathophysiological similarity between idiopathic dilated cardiomyopathy and ischemic dilated cardiomyopathy. So I will use this terminology as the discussion goes on. There are similarities in the pathophysiology, but then these are two different diseases and the treatment also is very different. While you use diuretics and ACE inhibitors and ARBs and maybe ARNI and beta blockers for both conditions, but you use statins and dual antiplatelet therapy only for ischemic dilated cardiomyopathy. So if you want to identify a zebra, look for its stripes. It is important to distinguish between idiopathic dilated cardiomyopathy and ischemic dilated cardiomyopathy. At the outset, it is important to say that it is wrong to call it idiopathic dilated cardiomyopathy because in many cases you see a lot of known causes, for example, alcoholism and maybe cancer chemotherapy with trastuzumab, and maybe some of these patients have a strong family history. So really, all of them are not idiopathic. Let us have some 5 pictures of idiopathic dilated cardiomyopathy. This is ischemic dilated cardiomyopathy. This is a patient who had old myocardial infarction and who's got a septum and anterior wall which are thinned, scarred, and akinetic. The left ventricle and right ventricle are both enlarged, and the systolic function is very poor. There is also a jerky movement of the interventricular septum. Contrast this with idiopathic dilated cardiomyopathy. The ejection fraction again is very poor. By eye estimation, you can say that it is almost 20 to 25%, but there is global hypokinesis. All the walls are equally bad in contraction. Same patient, look at the parasternal long axis view. What is kinesis? Kinesis does not mean movement to the echocardiographer. It means systolic thickening. Look at the walls, there is hardly any systolic thickening. So this is the characteristic of dilated cardiomyopathy. There is poor systolic thickening in almost every segment. Dilated cardiomyopathy. The annulus is dilated. There is very poor coaptation of the leaflets, and there is an eccentric jet mitral regurgitation. For the young doctors who may be happening to listen to my lecture, this is known as the Coanda effect, that is eccentric jet, and this is very severe MR. See, when there is an eccentric MR, then the MR becomes underestimated if you try to measure the jet area. But then it is important to look whether there is pansystolic regurgitation. Any pansystolic regurgitation, you can close your eyes and call it severe MR. Ischemic dilated cardiomyopathy, from the patient whose echo I showed you before. The septum is thinned, scarred, and akinetic. There is no systolic thickening at all in the interventricular septum. The posterior wall has undergone compensatory hypertrophy, and there is a pericardial effusion seen posteriorly. This is because of the failure and anasarca. This is another patient who I saw earlier this month. He has got a history of repeated myocardial infarctions. No intervention could be done because his renal function was poor, and you can see a dyskinetic effect apex, dyskinetic apex, and very poor systolic function. More about this diabetic and hypertensive patient as we go on along this discussion. A three-chamber view. See the poor contractility, but the apex is akinetic. Other segments are moving well, especially at the base. Same patient, see the dyskinetic effects, and there is a suggestion of an apical thrombus. Same patient, parasternal long axis view, very poor contractility, and look at the posterior wall, posterior inferior wall, there is thinning, scarring, and ekinesis. These are characteristics of ischemic dilated cardiomyopathy. Same patient, short axis at the level of the mitral valve. See the posterior wall, posterior inferior wall. Again, same patient. There are problems with eye estimation of wall motion abnormalities. Now, what I am saying now is from the American Society of Echocardiography's Comprehensive Echocardiography, 3rd edition, which was published earlier during this current year. What is normokinesis? More than 30% systolic thickening. What is hypokinesis? 10 to 30% of systolic thickening. What is akinesis? 0 to 10% systolic thickening. Then what is dyskinesis? It means bulging out or thinning of the myocardium during systole. What is aneurysm? The difference between aneurysm and dyskinesis is that aneurysm is dilated in diastole and remains dilated in systole. Dyskinesis is normal looking in diastole and becomes bulged in systole. The eye estimation of resting wall motion abnormalities is inaccurate. There are intra-observer variations. It means that you ask a specialist to comment and you ask him again 3 days later, maybe he will change his opinion. And of course, there are inter-observer variations. So if you want to distinguish between ischemic and idiopathic dilated cardiomyopathy, you take the help of this 2D strain imaging. 2D strain imaging by speckle tracking analysis predicts death or hospitalization. And what is this technology? You know, the computer selects at random some dots or points on the myocardium, and by a mathematical technique known as fast Fourier transformation, it goes on chasing those dots as the heart moves back and forth during systole and diastole. It notes the distance between the two dots in systole and diastole. During contraction, the distance between the two dots should be less because the heart is contracting. And conversely, the distance should be more during diastole. So this is more accurate and reproducible, and this is an objective method of measuring the regional wall motion abnormalities. Now, this has been applied also to the right ventricular longitudinal strain, and that was found to be more highly predictive than TAPSE and left right ventricular ejection fraction in patients with heart failure. So this is from our machine in Chattogram. You can see the bad motion of the apex, and see this is a scale. This red is good and blue is bad. So you can see the bad movement in the region of the apex, and this machine will also give you the ejection fraction. And one important thing is that don't try to measure the ejection fraction by the M mode. This is not done. It is unscientific. Same patient, free chamber. And we take help of the technology and we can get a 3D heart model which shows the contractility in various segments and also the different segments by different colors. There are times when the clinician is still in doubt because it is important to know whether the patient has got viable myocardium, whether there are stenosis. And if there is stenosis, the patient deserves revascularization. So for that, we use dobutamine stress echocardiography. In idiopathic dilated cardiomyopathy, there is generalized improvement in contractility. Of course, the contractility does not become normal, but then it becomes more than what there was in the resting state. And in ischemic dilated cardiomyopathy, the regional wall motion abnormalities will become exposed. And this was exactly what my old friend Chaudhry, Dr. Muskat Ahmed, was saying in his previous lecture. However, all cases are not so straightforward. The gold standard, of course, is invasive coronary angiography, but then you can use CT angiography with calcium scoring. A calcium score more than 400 Hounsfield units strongly suggests that the patient has got obstructive coronary artery disease. And also you can do cardiac MRI. MRI is coming to the forefront mainly because of its ability to show myocardial fibrosis by means of late gadolinium enhancement. Now, you have to understand this, that if there is no fibrosis, it is very unlikely that the failure has been because of ischemic heart disease. Now, the echocardiographer's job is not to tell the diagnosis only. He must also be able to predict the prognosis in a patient of ischemic dilated cardiomyopathy or idiopathic dilated cardiomyopathy. What are some of the features of prognosis? Low ejection fraction, that is too obvious. A large end systolic volume and end diastolic volume. LV mass, LA volume. LA volume is the glycated hemoglobin of diastolic dysfunction. The larger the LA volume, the more, the worse is the prognosis. The various grades of diastolic dysfunction. As the disease progresses, the diastolic dysfunction progresses and portends a bad prognosis. Dysynchrony, pulmonary hypertension, right ventricular dysfunction, severe MR, severe TR, and the absence of myocardial ischemia and viability. All of these will indicate poor prognosis. I will demonstrate some of the echocardiographic features associated with each of these predictors. Left ventricular end diastolic diameter. I repeat that it is better not to measure this by the M mode. We take a parasternal long axis view and measure perpendicular to the long axis at the tips of the mitral valve. We also measure left ventricular end diastolic and end systolic volume. Simpson's biplane method is a good method. And again, I showed you 3D real-time echocardiography. See, this is how we do at the tips of the mitral valve. And for young doctors who may happen to watch this, it is important to keep the junction of the aorta and the interventricular septum exactly in the midline and avoid foreshortening so that the results are repeated over various examinations from time to time. Biplane Simpson method. I am showing you only the 4th chamber, but again, the 2 chamber is also there. It accidentally got deleted here. You start measuring at one annulus, end at the other annulus, go over the apex. It is important that you avoid including the trabeculations. The trabeculations are a part of the blood-filled cavity. They are not a part of the wall. And again, the lateral papillary muscle here is a part of the LV cavity and not of the wall. The computer does the mathematical calculations and gives you the ejection fraction. Systolic function is traditionally estimated by the measurement of the ejection fraction and the ratio of the end systolic volume. This is done by a volumetric method by this summation by Simpson's method that I have already shown. 3D measurements I have also shown. Now, it is important to understand that although ejection fraction is a useful marker of left ventricular performance, it is dependent on the preload and afterload. The ejection fraction is a marker of ventricular load interaction rather than an independent marker of left ventricular contractility. Now, although DCM is traditionally considered to cause global wall motion abnormality, regional variations can occur. For example, inferolateral hypokinesis or akinesis have been observed in muscular dystrophy associated dilated cardiomyopathy and acute myocarditis. When endocardial definition becomes difficult because of challenging echo windows, the use of ultrasound enhancing agents, echocardiographic contrast, can be extremely valuable. It can permit better visualization of the left ventricular and right ventricular endocardium and facilitate more accurate assessment of dimensions and systolic function. What is more important is that contrast can help diagnose left ventricular thrombus. I have shown global longitudinal strain, and I've also discussed about the fast Fourier transformation. It is an enhanced method of assessing left ventricular systolic performance. It is valuable in unraveling subclinical left ventricular dysfunction, which may be missed by traditional echocardiography. Strain quantification is useful in cardio-oncology for monitoring of chemotherapeutic cardiac toxicity and screening family members of dilated cardiomyopathy for subclinical LV systolic dysfunction. Now, one of the important prognostic factors is LA volume. Again, it is better to measure it in two planes by the modified Simpson's method. We start at the annulus, we trace the interior of the left atrium, end at the other annulus, and importantly, join the two annuli by a straight line. Some young doctors will make this mistake. They will trace the undersurface of the mitral valve. Don't do it. And from the midpoint of the line, join into the two annuli, join the distal most point and press enter. The measure, the computer divides the LA volume into 20 equal slices, just as you cut a loaf of bread into slices, and using the two planes, it gives the LA volume. It is important to measure it in full systole with the mitral valve tightly shut, and importantly, don't go into one of the pulmonary veins because that will cause overestimation of the LA volume. When doing evaluation of dilated cardiomyopathy, whether idiopathic or ischemic, remember not to miss secondary mitral regurgitation. It results from apical papillary muscle displacement and annular dilatation. It is an important cause of adverse prognosis in dilated cardiomyopathy, and randomized clinical trials.
1 minute remaining.
How much time, ma'am? 1 minute. Okay, I'll finish it. I'm near the end. The randomized controlled trials have evidence to support intervention in secondary MR using transcatheter edge-to-edge mitral valve repair. Echocardiographic assessment involves evaluation of potential exclusion criteria, namely severe dilatation, RV dysfunction, pulmonary hypertension, and severe TR. It is important to measure the LV diastolic dysfunction as well, and the two important things that are measured in the AAC recommendation are mitral valve pulse wave Doppler, the RV index of myocardial performance, which can be done by pulse wave or tissue Doppler, and the velocity of tricuspid regurgitation. There are algorithms which tell you which grade of diastolic dysfunction it is. The echocardiographer's job is also the guidance of therapy. For example, in alcoholic cardiomyopathy, reverse remodeling, eligibility for the implantation of AICD, the EF has got to be less than 35%, transcatheter mitral valve replacement and tricuspid valve intervention, timing of left ventricular assist device and cardiac transplantation, assessment of CRT. Although this is based on ECG criteria, there is additional evidence that echo evaluation is of incremental value.